is Dr. We are recording this. So my name is Dr. Zipporah Ali. I formerly worked with Kenya Hospices and Palliative Care Session for the past, from the inception, let's say from 2005, and finally worked as the executive director, just retired last month, but still very passionate about palliative care. As you can see, I'm still nosing in and taking active part in it. Our speaker for this evening is going to be Dr. Catherine Peters. So I'll introduce Dr. Catherine Peters first and then give her an opportunity to give us her presentation. And then later on, I'll do some just sharing on with everyone how we managed to do our advocacy in Kenya as well. And I just want to let you know that about 60 people registered, so they will probably be joining us as the session goes on. But some of them are also watching our session on Facebook. We are streaming live on Facebook, and most Kenyans prefer Facebook, but I think because it actually doesn't eat so much into their data bundles. So welcome everybody. I see we have got speakers from all over the world, and that's amazing. Really amazing to see all of you, and really amazing to see Lucy Watts. Lucy is a patient advocate, a really strong advocate up to the UN level. So a little bit about Catherine. I've known Catherine for many years. Catherine is a very passionate person for palliative care, and not just, she actually focuses on the holistic approach of palliative care from, physical symptom management. She has advocated a lot for the, for opioids, availability of opioids across the country, for addressing the laws and regulations that are very stringent on opioids, so that they are more friendly to us clinicians to be able to support our patients. And Catherine has really supported many of us, I'm one of them, in terms of how we should be able to do our advocacy and reach out to our health ministers, to our representatives in Geneva, and has helped us even draft speeches for the UN meetings and WHO meetings. So she's very passionate about what she does. She really also believes in human rights, so she uses the human rights approach. You should not cross her. If you're doing something that's against human rights, she will really be on your back. So Catherine, thank you very much. We have so far 28 online and others on Facebook. I can't tell how many you have on Facebook because I'm not logged into my Facebook, but I'm sure there's also a big crowd there, and others will be joining as we continue. You can tell us a little bit about more yourself, and then we can start the session. And yeah, you're welcome. In Kenya, we say karibu sana, which means welcome in Kiswahili. Karibu sana, Catherine.
Thank you. This is almost as good as being there, but not quite. I'd love to be with you in person, but then now we get people from all over the world, which is amazing, as you said. So welcome everybody to you. I'm in San Diego, where I first met Zippy. She makes me sound a lot more important than I am, because honestly, we're all making this up as we go along. None of us knew how to do this when we started. And I'll talk a little bit about that. But my degree is in political science and political theory and policy. But I'm also a trained hospice volunteer, and I was the caregiver for my sister who passed away in March. So in that sense, I've been a member of a multidisciplinary team at Hospice, San Diego Hospice, which doesn't exist anymore. So I know whereof I speak a bit about multidisciplinary teams. And then when I work for the International Association for Hospice and Palliative Care, which I will talk a bit about. And I'm in San Diego, like I said, because I can't be in Europe for the meetings that we usually have in Europe during this season, but that's fine because I've got lots to do. So whenever you want, I'll start my presentation, Zippy.
Go ahead, this evening is yours.
You ready? Okay, so I'll share my screen then.
Yes, please.
Okay, let's see. Hold on a minute. Sorry, guys. I already tested this and it worked, so I should be able to do it properly. Let's see. Here we go. Share screen. can I find it? Sorry, now I'm not finding that presentation. It was right there a minute ago. It's right here. Oh, that's the wrong one. Final Kenya. Okay, here we go. Thank you for your patience. I'm sorry, I'm not being able to open this. I mean, I can open it here, but not in the screen sharing function now.
Let me just ask David,
Oh,
is
here we go. Sorry, Zippy, I got it. Can you see it?
okay. No,
got
not
it?
yet. Not yet. No.
Oh, shoot.
I think
Okay, maybe is Howard still with us?
David is with us. David is
David,
behind
do you have my slides?
I can share it also. I have it. You want me to
Oh,
share
brilliant. Brilliant.
Yeah.
You share it then, and I'll just say next slide, okay? Sorry, I had it all ready to go.
Yeah.
Okay, so
Right.
you want to go up to the first one, Zippy? Yeah, there we go.
Yes. Yeah.
So yeah, so this is me, and I'm the advocacy officer, and there's my email. So then next slide, Zippy, please. This is how I'm organizing the presentation. It's a huge amount of ground to cover, but I'm going by what the organizers of the webinar asked me to do. So, you know, I'm going to introduce IHPC. I'm going to talk about why we do advocacy, because it's a new concept to a lot of people who are providers. You don't learn it in medical school. Patients certainly don't learn it. And the best advocacy, like I'm going to talk about, comes from both providers and patients. The topics we advocate for at IHPC, messaging, and I was asked to talk a little bit how to package palliative care for advocacy, principles of palliative care advocacy, which I've seen as we develop this. Like I said, we're making this up as we go along because we never had professional advocacy. Everybody multitasked all the time. Methods and how to influence policymakers, again, what we've learned on the ground, and then some recent wins, and then question and answer, and then Zippy will be talking a bit about her work like I asked her to. Okay, next slide, please. So the International Association for Hospice and Palliative Care, I think it's 25 years old. It's quite, it dates back to the 80s. Well, no, it's older, definitely. It was founded by a Filipina oncologist. I mean, the original organization that metamorphosed into IHPC was founded by a Filipina oncologist, Josefina Manyo. We're a global membership organization. You can join as an individual or an institution. Our vision is a world free from health-related suffering. Our mission is to be a global platform to inspire, inform, and empower individuals, governments, and organizations. So we want to empower governments, you see, and to increase access and optimize the practice of palliative care, which of course includes access to palliative care medicines. We're also a non-governmental organization. Sorry for all the acronyms, everyone, but that's just UN alphabets. And if I spelled them all out, it would take up too much text. A non-governmental organization in consultative status with the UN Economic, Social Council, Economic and Social Council, ECOSOC. And a non-state actor, they have different terms, in official relations with the World Health Organization. All that means is that we have official status to participate in what are called multilateral meetings. That's meetings between your governments, UN member states. That's the basic building block of the international system, are member states, governments. And we're what's called civil society or NGOs. And theoretically, we're supposed to be legally included in all these meetings, but you have to go through quite an extensive process to be approved. And Liliana de Lima, who's my boss, has taken IHPC through all those steps of approval. And then once we have that status, then we can do advocacy, we can do technical consulting with different UN organizations, and we're invited to different kinds of projects. Like, for instance, the World Health Organization right now is developing new guidelines because they withdrew the originally great ensuring balance guidelines on access to opioids in the world. And I won't go into that long story, which is actually all on our website. But so now there's this what's called a guidelines group, which is developing new guidelines. And we weren't invited to be part of that, but other non-state actors are, and other NGOs and people who belong to our organization are participating in that, but officially we're not. And then we're asked to consult. We get all the emails about different meetings, and then we share that with our membership so that you can participate. And in that capacity, we coordinate what are called national advocacy focal points in all the World Health Organization regions. Zippy was our advocacy focal point for Kenya with David, and now we have two new advocacy, or one new advocacy focal point, the new executive director, Makalai. So, and we have advocacy focal points in Zambia, Bangladesh, India, Germany, Australia. You get the picture. And then I train them I mentor them to participate and work with their government in these international meetings. And of course, you can read much more about this on our website, hospicecare.com. Next slide, Zippy, please. So the purpose of palliative care advocacy is basically to raise awareness, because as most of you know, the governments and the public around the world and the media don't have a very clear idea about palliative care and what it is, what it's for. They think most people think it's just for cancer, for end of life. Some people, unfortunately, confuse it with euthanasia. So there's this huge educational piece that we have to do in the beginning to raise awareness about the unmet clinical needs for palliative care, about what palliative care actually is, and the work being done on the ground to showcase that. So part of advocacy is to showcase the work that the NGOs are doing on the ground to the governments, to show it can be done and the kind of relief it brings to patients and families. We try to raise awareness about gaps in policy frameworks, because there are huge gaps where policy doesn't mention palliative care, doesn't fund it, doesn't allow for workforce training. So we have to fill all those gaps. And of course, about the benefits of palliative care, which most people are completely unaware of in terms of quality of life. But the thing that we also try to do at the international organizations where we do advocacy, and which you can do at your national level, is to normalize palliative care, to use those words in the global, regional, and national public health agendas. The words palliative care are left out of nearly all the documents and reports when they were originally drafted. And then through our advocacy, we've been able to get it included. That's just the first step. And then there's the hard work that's done on the ground to implement the language that's in those documents. But if you don't have the language in the documents at all those different levels of governance, then it's really hard to have any leverage with your governments to say this is something you need to do. Sorry. So next slide, please, Zippy. So the topics of palliative care advocacy, these are the main things we advocate on, is access to medicines, which, as you know, are controlled substances. They're not just like antibiotics or other prescription medicines that are not controlled under international conventions. So we work at CND, is the Commission on Narcotic Drugs. We work, as Zippy said, on human rights to health, and it's at the Office of the High Commissioner for Human Rights. And that's where we work with the Special Rapporteur for Health. Usually, for instance, the last Special Rapporteur for Health, Danias Puras from Lithuania, he visited Hospice Africa Uganda when he came for the Kehpca conference a few years ago. He actually went on home visits with the team, which was wonderful. He participated in side events at Commission on Narcotic Drugs for us. And the new Special Rapporteur for Health is from South Africa. And she recently participated in a side event. We had two on the right to health, right to palliative care as part of the right to health, and the right to be free from torture, cruel and inhumane punishment, which is how some of the human rights experts have defined lack of access to palliative care medicines. Because if they say that if governments don't ensure access by protecting the right to be free from cruel and inhumane treatment, that can be tantamount to torture. So that's been officially reported as a violation of human rights. We work on the rights of older persons to palliative care at the Open-Ended Working Group on Aging, which is a UN working group that's working on drafting a convention, hopefully eventually, but at least showing the need for a binding convention on the rights of older persons. So the reason I get involved with that is with Help Age and with the different organizations working for older persons is because older persons need a right to palliative care. The only place in the world that they have that is in Latin America, because there's a regional convention on the rights of older persons in under the Organization of American States, which contains a right to palliative care now, thanks to advocacy that took place before I was hired. But it's a wonderful right there. And the African Union, we worked with them to get palliative care into their common position, but it's very sketchy. And a lot more work needs to be done with the African Union. We don't do much direct advocacy on the rights of children. We advocate for everybody, people of all ages, but ICPCN, the International Children's Palliative Care Network, and I know Joan's on this call, is really specifically focuses on the rights of children. The rights of persons with disabilities to palliative care is very important. We do that at the World Health Organization, the Open-Ended Working Group, and the Human Rights Commission. And then service delivery, obviously, in equity with the World Health Organization. And we actually share that task very much at WHO with the Worldwide Hospice and Palliative Care Alliance. We have a real division of labor there with WHO because there's so many different divisions that we work with. And we have a joint project with WHO now, which is going to culminate in World Hospice Palliative Care Day on October 10th. So these are the basic topics we work on. Next slide, please. Zippy. So thank you. Messaging and how to package palliative care. I think one of the main messages that we have to keep getting across is that it relieves suffering associated with chronic disease, with infectious disease, HIV/AIDS, with COVID, with cancer, with life-limiting conditions. And by limiting, I don't mean in time necessarily, but in what people can do, because as we all know, really basic palliative care can really increase people's capacity to participate, to go back to work, to be part of their families, their faith communities. So it relieves that kind of suffering along multiple domains. It's the only clinical discipline, as you all know, that explicitly addresses spiritual domains of suffering. And I think that's what really distinguishes palliative care from many other, that it's interdisciplinary and it contains 5, 6, 7 different disciplines because that suffering can be very complex. So that's one important message with policymakers, that, as you all know, once someone's condition is deemed untreatable from now on, they're sent to go home and they're told there's nothing more we can do. Well, we all know that there's plenty more that can be done. So that's the message we have to get across, that it improves quality of life and sometimes length of life. It's an ethical imperative of all health systems. That's the language from the World Health Assembly resolution of 2014. It's not optional in that sense. It's an essential component of primary health care and the right to health. That's from the Astana Declaration and also obviously the Human Rights Conventions. So these are all, these things that I'm talking about now, these are commitments that member states, your governments have made about palliative care. So we also remind them of that as we package our advocacy message. This is a bit of a grab bag, but as Zippy said, I support our advocacy focal points to choose what it is you want to get across to your policymakers. I think it's very important to communicate that it supports resilience and sustainability in families and communities. That if you think of it, how a family and a community and a patient suffering from really serious illness without palliative care, the lack of resilience and sustainability that family and community has. So they become very weak. The political trust is weakened, and their trust in the community, their availability to participate is really weakened. So palliative care supports resilience. It's appropriate for all cultures, faith traditions, and income levels. It can be delivered very simply and inexpensively at the community level, and it saves costs at the tertiary level often by avoiding unnecessary, for the health system, hospitalizations and medicines purchases. And again, tied to the resilience and sustainability, it leaves no one behind. So these are all different types of ways you can package your messages depending on who you're talking to. Next slide, please. Some principles of palliative care advocacy that I've developed as we go along. I think it's really important to have that your advocacy embodies commitment to your patients and families, and to one another, to your colleagues, but that the patient and family always comes first. It's very important to have endurance. This changes so slowly, it's glacial, and it's very frustrating because the families and patients are suffering now, and yet this is the long game. It takes a long time. So you have to be in it for the long haul. And again, resilience, self-care, I know how hard that is, and it must be even just harder when you have families, jobs, other things to do. Resilience is built out of self-care, which is seen also as community care. It's not selfish, it's not self-indulgent. It's the only way that we can take care of others. Intentional inclusivity is a really important principle to me, which is the tagline of leaving no one behind. It's equity. So that requires you to tune your ears and your eyes to who's not being seen, whose voices are not being heard in your advocacy. And it's usually people with disabilities, it's usually older persons, the people who are shut away and invisible. Children, Joan is really good on making sure that children's voices are heard and parents' voices are heard. So think about who's not there. And that's what I always try to bring in, is who's not there. And then mentorship is an important principle, because we stand on the shoulders of giants, and I need to be mentored. And people who are doing advocacy for the first time, or they've been doing it for 10 years, still need to be mentored about what's going on, because there's so much going on right now. This little picture was from Eduardo Barrera, an Argentine palliative care doc who works in Houston. And I just thought that was a useful handbook for self-care at work. debrief, mute movement, nap time, that would be nice, but still. Next slide, please, Zippy. You get the picture. How to influence policymakers, press, and the public. I was asked to talk about that. To me, the most important thing is to build relationships and to build trust. You can't do it with emails, letters, cold calls, unless you have a relationship with the person. And that's tough. You have to find out who your influencers are in your government. It may not be the minister. It may be the secretary. It may be a civil servant you haven't identified. You need to build a relationship with the people who are going to make the change. The second one I think is very important is to come and see. And that's been really hard in COVID, but it can still be done through video links. Come and see what we do. I learned that by being a volunteer on the teams. I wouldn't have known otherwise what palliative care was. Come see what our service does. Invite media. I know you're really good at this, Zippy, but invite media and policymakers on ride-alongs. That's what they called in the States. You go along with the team, you ask permission of the patients and families if this other person can come, and they see what you're doing. Because often if you don't see it, you really don't understand what palliative care does. It's really important to build transversal alliances with other NGOs in your country. We're tiny, we're a tiny, not strong NGO in terms of power in the international arena. So together we're much stronger. So with the NCD community, the HIV/AIDS community, the disability community, the older persons communities, you know, your imagination is the limit in terms of the other organizations you can partner with to make the case for palliative care to your policymakers, because all these people, all these groups of persons are going to need that. Hold public and media events, press conferences, do whatever you can to raise, again, public awareness. That goes back to the first slide. And I think it's also very important to designate an advocacy focal point for your national palliative care association on your interdisciplinary teams, so that someone can become an expert, quote unquote, in advocacy, and they can be the person who is the go-to person, just like the nurse or the spiritual care provider or the psychologist. Oh, there's an advocacy person, so he or she will contact a government minister if, for instance, as you just went through, PPE is needed, or you need other things. You have a training session and you want to communicate about that. So there is some infrastructure building and relationship building that needs to be done in order to have some effective influence. So it's not just policymakers, it's also the press, and then the public, often through social media and through traditional media. Next slide, please, Zippy. So to me, evidence plus stories is advocacy. You have to know the evidence about your country. And this part of the slide is just a screenshot of our, it's called the global data platform for, and so it's interactive and you can go to any country in the world and find out the rates of serious health-related suffering in your country by disease. There's, I think, 10 different disease conditions that you can search by: cancer, HIV/AIDS, TB, and other conditions. You can also look at pain management, and there's very detailed instructions on our website about how to use that database. Zippy, could we go back to that last slide, or am I running short of time? Okay. And then also stories are really important. So you need both. You need the legal framework, you need the evidence, and you need the stories. It's got to be personal. And of course, you have to have the compassion. You don't just deliver this like it's data. And that's why it's so important that we have providers and service recipients as the most authoritative advocate. I'm not the best advocate because I'm a policy person who mainly works behind the scenes. The best advocates are you, who provide the services and receive the services. And then you talk legitimately and strongly with authority to your policymakers. Thanks, Zippy. Next slide. Zippy.
I'm here, it's hanging. Let me try.
Sorry, I wish I had mine.
It's, oh.
You had it
okay,
up.
fine. There it is, yeah.
Okay, so this is some of the main evidence. There's the global platform, which I already talked about. There's obviously the Lancet Commission report, which contains the information about the essential package, which is a really important thing for advocates to know, that the health economist who worked in the Lancet report just figured out the basic essential package for countries of all different income levels, so sliding scale, about what you need, what a health system needs to deliver palliative care. And it's usually less than 3% of the health budget. It's important to know that. There's quite a few WHO guidances now, especially on COVID, on primary health care, on pediatrics, and on emergencies, which talk about palliative care. There's quite a bit now because we really pushed on it. There's the UN Office of Drugs and Crime, technical guidance on pain management. There's a wonderful book, which you could look up if you've got time, called Compassionomics, which is by some Chicago researchers on the fact that compassion actually makes a difference in the economics of health systems. And they've done the experiments, they've done the numbers, and that's quite good for advocacy if someone's interested in digging deeper. And then, of course, create an archive of short videos with patients and providers so that you can just show, a 3-4 minute video of the work that you do and why it's so important, because often you cannot get those patients and families and show the setting they're in to talk in person. Thanks, Zippy. Next slide, please. Oh, now we're going back, I think, aren't we? There we go. So these are some milestones. The World Health Assembly palliative care resolution in 2014, which is when I was hired. The UN, it's called UNGAS, which is UN General Assembly Special Session on Drugs, was in 2016. And chapter 2 of that document, an entire chapter, 7 operational paragraphs, now discuss and have very pragmatic and practical recommendations to governments about how to improve access to palliative care medicines and how to improve access to services even. That is, I think, is one of our big triumphs of advocacy, because all the Commission on Narcotic Drugs documents up until then just basically had, if we were lucky, a short paragraph, but maybe a sentence on the need to include palliative care medicines. That was all, without diversion and abuse. It was like this packaged sentence or paragraph. Nobody had any really good insight into how to do this. So now we have this chapter 2, which is fantastic, and Zippy really helped with that and did advocacy on that. The Astana Declaration on Primary Healthcare in 2018, which replaced the Alma Ata Declaration on Primary Healthcare, which is like the constitution of primary healthcare in the world from 1978. And that, the sequence of services that document mentioned for essential health services ended with rehabilitation. It went prevention, promotion, treatment, rehabilitation. And I took one look at that and said, well, where's palliative care? So we worked very hard to get palliative care into the document that was created for the 40th anniversary, which was to modernize the Alma Ata Declaration. So now the whole world has agreed that palliative care should be part of primary healthcare, including your governments. The political declaration of the high-level meeting on universal health coverage, again, the original document didn't include it. We made sure it was included. We really worked with the Worldwide Hospice and Palliative Care Alliance on that and colleagues around the world. World Health Assembly Resolution 73-1, that was last year on COVID-19 response, thanks to our advocates in Zambia, working with their government. Palliative care was included in pandemic response. So if you can imagine, the World Health Assembly had drafted a resolution on what member states should do to respond to COVID, all the health services they should include, and they didn't include palliative care. It's just stunning. So thanks to Zambia, it's now included. And again, the hard work is to implement that on the ground, but you're authorized to do it. That's the point. And then upcoming, we've got an UNGAS, again, UN special session on a pandemic framework treaty. And we'll have to see, we don't have any of the modalities or zero drafts of that, but we want to make sure that we're included in some of the negotiations on that in case palliative care has to be included. It may just be, it may not name health services. It may just be very general and about principles, in which case it won't be appropriate, but we have to see. So civil society advocacy creates a policy through line from UN organizations to the bedside. It's like a circuit that we create from the bedside to the UN and back again. Next slide, please, Zippy. How am I doing for time? Do I have 10 minutes or 5?
You're okay.
Okay, because I'm just going to do a little case study on UNGAS, the one that I think is our really big accomplishment. On access to controlled medicines. Next slide, please. So access to palliative care medicines, many people don't know this. I certainly didn't know this when I started out doing this. It's a function of international drug policy. It's implicated in the Single Convention on Narcotic Drugs, which was ratified by all the countries in the world in 1961. It consolidated all the colonial era drug policy treaties, which took place and were drafted since the 19th century. But the Single Convention consolidated all those, and it has things called schedules or lists that are attached to it that contain the names of the medicines that are under international control. And guess what? It contains most of the palliative care essential medicines and opioids, which are also on the WHO essential medicines list. So you've got this double essential for health, but controlled under the International Drug Control Conventions because they could cause addiction. This was before palliative care was developed as a specialty, and it's very important to remember that. I'm going to go through that timeline very quickly. The important thing to remember is that the goal was to prevent diversion and abuse. It was not really to ensure access, even though lip service was given to access and relief of suffering. There were no clauses or operational paragraphs in that convention which explicitly directed member states to make sure populations had adequate access. The other good thing about it, though, is even though it gives lip service to the fact that suffering shouldn't be allowed, that local manufacture and joint procurement are allowed. And these are our main goals at the moment, especially with COVID and all the supply chains going down. So many medicines that are only from the raw materials come from India, China. If those supply chains have broken down, prices have gone through the roof, really local and regional manufacturing is going to be really important. And then local and regional banks, such as the East Africa alliances, the East Africa Bank. Sorry if I haven't got some of those names right. This was the original slide set. I refined it a bit with the one I can't find. So this is just a picture of the Single Convention. Next slide, please. Oh, I think we missed one because this is here. Okay, the next one, Zippy, the one with the funny picture. there we go. I worked on this quite a bit. I know this is peculiar, and I had to think about why this is so hard and why this is taking so long. And it's just like pushing this huge rock uphill. So this is a drawing of a glacier, if you can imagine it. It looks like an arrowhead or something. Anyway, this is a glacier. And this was when the Universal Declaration on Human Rights was signed. 61, you have the Single Convention. 63, you have the founding of St. Christopher's Hospice. Island Hospice was the first in Africa. The 80s, you have the US hospice movement. 83, Balfour Mount in Canada coined the term palliative care after he'd worked with Cicely Saunders in London at St. Christopher's. And then you had in the 90s, the development much more of hospice in Africa with Hospice Africa Uganda, and the early literature on the palliative care and hospice movement and meds availability starts coming out. If you do a literature search, it really starts in the some in the 80s, but 90s. And then late 20th century, early 21st century, you've got worldwide development of service development. So this is what I call the 40 years dark ages of the drugs narrative. Drugs are bad, drugs are, and palliative care medicines, they weren't called that then because palliative care really didn't happen until the, as I said, this part. But advocacy wasn't really professionalized. I didn't start this work. So as that was the only thing that's my job is advocacy. So I'm not trying to multitask with being a provider, with trying to be a pharmacist or whatever. This is all I do is advocacy. 2014, serious health-related suffering wasn't even measured. And that's what's on that database I showed you until 2018. So there was no real data at the global level or at the country level about suffering. You all knew in your countries what was going on. But you know, we also know that what isn't counted doesn't count. So you've got to have data. You've got to have some professional advocacy. And we've only got 6 years of this. And to me, that helped explain why this is so difficult. Even though it's self-evident we have to do this, we have to bear in mind that we're very young. We're only 6 and we're learning. And that's why I said we're in this for the long game. And the Young Gas was 2016. So, you know, we're here now and we're really in the implementation phase because as I showed you from the slide with the accomplishments, we've got the international framework laid out now. It's what I call the international pallium, the covering. We've woven this pallium of words into the international documents to authorize practice at the national and regional level. And now it's the work at the national level. And that's what I can help you do as much as possible. But you know your national scene much better than I do. Next slide, please. And so this is the end. And this is Zippy at the Commission on Narcotic Drugs in the lead up to the Young Gas, because she came to Vienna and she helped with some of these panels, talked about the situation in Kenya with the ambassador from Kenya. You remember that one, Zippy? And came to New York, talked about that. We had Rose Kiwanuka, who was the president of the Uganda Palliative Care Association, come to New York and testify at a hearing. So that's what we just have to keep doing, is showing up, telling stories, sharing the evidence, and being committed that this is not optional. It's for our patients and it's for the world. So thank you. That's it. Oh, and references. Yeah, you've got the references.
I'm getting to them. Okay, there they are.
Yeah, and this won't show up. Yeah, sorry, Zippy. This won't show up in the PDF, but the links are live if you share the slides. That's up to you. Yeah. Yes.
Thank you very much, Catherine. Thank you for that wonderful presentation. We usually share the slides because people would like to go back and look at the slides and learn from them. We usually PDF them so that we don't have somebody using your slides directly to give a session somewhere else. And we also have this recorded, so those who wanted to get the recording can get the recording. but also the session will be on Facebook. So those who also want to listen to it can listen to it on our Facebook page. So thank you very much, Catherine, for sharing about all that we've been doing in advocacy. And I hope we are still listening. I think there are about 45 people here right now, and other people are on Facebook, but I've been seeing messages saying that there are 2, 4, 5 people listening from one gadget. So that's great. We are probably more than 45. But it's good to see that people are sharing gadgets and sharing their bundles to listen to this important session, because we wouldn't have palliative care if we didn't have advocacy. If we didn't have the advocacy, we probably wouldn't be having palliative care. And I think advocacy is very important. It is very important because even as much awareness, as much as you can create awareness, if you don't do the advocacy, the awareness will just remain as awareness. Now you need to do the advocacy so the palliative care is fully integrated into the healthcare system. So I just want to also acknowledge that Catherine, people like Catherine have helped us with our advocacy to think through it. People like Jean Cleary, who help us with access to opioids when we started Kehpca in 2007. People like John helped us understand why it's important to advocate for children and other vulnerable populations. Again, Dr. Faith Monkey when she worked with APCA, was very instrumental. Claire and Connor at WHPC were also very instrumental in helping us understand the global advocacy, the global approach to advocacy, but also helping us how we can bring this global perspective into our own national advocacy. And I think advocacy at the national level is also very important, and not just at the national, like the government national level, but right up to the community level. As much as we create awareness, we also need to advocate that even at the community level, the community health workers actually embrace palliative care and are able to support it. So for Kenya, we have actually done quite a lot over the past 14 years. We've actually managed to get our government to embrace palliative care, to take it as part of the services that are supposed to be given to our patients. And Catherine, you talked about palliative care being excluded from one of those statements. For us, we got it right when we wrote our Patients' Rights Charter in Kenya in 2013. It said every person must have access to promotive, preventive, curative, rehabilitative, reproductive, and palliative care services. So we managed to get it there. We screamed until they put it there, and now they're thinking of adding mental health as well. In our health law, law also says the same thing, that we should have a right to all those services, including palliative care. But of course, these are documents. Sometimes they can remain as documents unless you really push for it. So we have been working with a lot of people in this country, especially the palliative care providers, the nurses, the doctors, the clinical officers, the social workers, the chaplains, the support groups in those hospices and hospitals are really our main advocates. They advocate every day. They're taking care of that patient. When you do something that shows it is good for the patient and the family, it's also beneficial to the system, then actually you advocate that this is a service that is going to be helpful. So what they see is evidence of what palliative care can do. And that for me is the biggest advocacy, that we can see the evidence of what palliative care is doing for our patients. And those of us working in palliative care can actually share that it makes a difference. When I was working in Kehpca National Hospital, I didn't really understand what palliative care is. I didn't even know anything about pain management apart from giving people Panadols, and opioids were being used only for post and pre-ops, patients. And when I started volunteering at the hospice in 1993 as a young doctor, I looked back later on and I felt so guilty and so sad that I had not really practiced medicine the years I've been working in the National Hospital. I realized I was practicing medicine once I knew what palliative care was, because I realized palliative care is holistic. It's about the patient, the psychosocial issues, the physical issues, the spiritual issues, the family issues. And so it really is important that we embrace palliative care. We advocate for it to be part of what we do in our day-to-day life with our patients and their families. And in Kenya, we've actually done quite a lot. We have managed to get palliative care into the nursing curriculum. We've managed to get into the medical curriculum, although it's I don't know how much of it they teach. Sometimes they teach and sometimes they don't. We have managed to get it into the pharmacy curriculum, and now we are trying to get into the clinical officers. So we are trying to ensure that it's part of the core curricula for healthcare workers, anybody working in the healthcare system. And slowly, I think we'll finally get there. We managed to get it integrated into the public hospitals, the mission hospitals, the private hospitals as well. And of course, we have a few hospices that are also providing palliative care. In 2012, when we started working, when the when all the global advocates and national advocates came together and said we have to make people in Geneva understand, or the people at the UN or WHO understand what palliative care is. Kenya was actually the first country to host a side event in 2012 in Geneva. We are the first person. We wrote to our ambassador in Geneva. We asked him, we want a room to hold a side event, and he was very, very supportive, Dr. Tomboya, and he said, I will organize it for you. He organized a room for us. We didn't have the funds to do everything else. So Open Society Foundations came in to fund whatever logistics needed to be done to bring the people to speak to the conference. We had America as part of our partners. We had Panama, we had Australia, we had Uganda. So we were a strong team. And I remember when we were having the World Health Assembly during 2012, we were actually dishing out pamphlets to people before the session. Please come to our session, please come to our session. And we had a full house when the session started. And one of the speakers, the main speaker, the key speaker was Dr. Kimani from the Ministry of Health. Dr. Kimani had been very difficult when I approached him earlier, talking about palliative care, the integration of palliative care. I think I went to the ministry for almost 1 year without getting to see him. And one day he said, tell her to come. Tell her to come, I'll see her and then finish with her. And when I was going, I didn't go alone. I took Dr. Munyoro, I took Dr. Kilingo, who was our chairman, and we went together, the three of us. And he said, I'm seeing you simply because I have an auntie in my house who has got cancer of the cervix, and I have no idea what to do with her. And that was, for us, that was it. That is what we needed to hear from him. And we told him, don't worry, we will know what to do with her. Just tell us where your house is. We will ask the Nairobi hospice to go and see this patient, and your problems will be solved. And I think they went to see the patient, of course, and I think that really changed his mind about palliative care. In about 2 weeks' time, I was called and told, come and pick a circular to ask us to work with the public hospitals to integrate palliative care. So actually, we also have a history in what has happened globally in terms of the World Health Assembly, in terms of the WHO resolution we had drafted. And I'm really glad to say that we have actually embraced palliative care in Kenya. We have a lot of challenges. We have funding challenges, we have human resource challenges. I've just come from Eldoret and Kimbilio Hospice. The last 2 days I've been out in the field, actually just flew back at lunchtime so I could be in this session. But you hear a lot of challenges out there. We might have done a lot of advocacy, but we haven't managed to get a budget for palliative care in the country. So we are now working on a policy. We have actually gotten a draft. And I think, Catherine, I should send you that draft to also be an external reviewer. We are hoping that this draft will help us change some certain things. For example, how palliative care included in the UHC package, how palliative care included in the budgets for the national, at the national level, at the county level. So palliative care advocacy works only if you really do it with other people, not by yourself. You have to do it with the patients as well. And I saw Lucy Watts here, who has been a very great advocate. And we have been working with patients in Kenya. We've been working with people living with palliative care needs to be in the forefront of advocacy, because they understand what they're going through. They have the lived experience. And these days we say nothing about me without me. So we have to put them on the table as well to be able to tell us what their needs are. And when you go with a patient and the patient tells the policymaker, this is what I'm going through, it makes a change. Susan, one of our champions, patient champions, has managed to get 5 million Kenyan shillings from her governor to actually start a support group for breast cancer patient survivors in her county. So I think we are all part of advocacy. And I want to say advocacy is everyone's business. It's not Zibi's business, it's not Catherine's business, it is everyone's business. Those who take care of the patients themselves, the family members, the leaders in the global leaders, support us, help us draft letters. Catherine has helped us many times draft a letter to the Minister of Health. This is what you should put in, that's what you should put in, adapt it to your own country. So sometimes I don't have time to draft those letters and use that language that you use, but I'm happy when you send it to me that I can now put Kehpca and say this is going to, so it's very important that we all get involved in advocacy. And I want to say thank you very much again, Catherine, for sharing about your advocacy work. But I think the fact that we are all here, it means we are all advocates. And it's good to see advocates from across the world. We have people from countries that I have never even been to here today. And we have people from many other countries in Africa. So thank you very much, all those who have attended this session today. I think we'll go to the question and answer session. And I want to see if there are anybody has put any questions. John has said we need palliative care to reach into humanitarian settings despite many challenges. And Anonymous has said, I'm wondering whether there is a skill set needed to do advocacy and whether there are accessible courses to take up. So I'll ask Catherine, you are our guest speaker, if you can respond to those two questions.
Thanks, Zippy. Didn't sound like Jones was a question. I totally agree.
Yeah, it's a comment. Yeah. But
Yeah,
you can add to the comment. You can add to it.
Joan has been really a leader on this humanitarian situation, and thank God she was, because that was pre-COVID. And we've been, thanks to Joan and thanks to other colleagues, we've been able to get palliative care language into some of the COVID response documents. And, you know, there's still a ton of work to do because, as you know, the emphasis is on saving lives. That's the only thing. And people don't think about what happens when the lives cannot be saved, or the lives people aren't going to die, but they need help with the quality of life and resilience piece that I was talking about. So it's a huge part of humanitarian emergencies, refugee situations, migrant situations. As you know, Zippy, you know, you've got the refugee camps. Uganda's got the refugee camps. And when I was in Uganda, we went to some of the refugee camps and tried to get palliative care services just marginally involved. It's uphill, but it's got to be done. And then in terms of the courses, we have a basic advocacy course that is on the IHPC website, which is for IHPC members. I recorded it 2 years ago, or 3 now, before COVID. What it does is it basically gives you a tour of all the UN organizations where we work, what we do, how we do it, which documents came out of it, a much more expanded version of what I did today. That is a members only course, but now because of demand, people are really interested in learning more about advocacy. I'm developing an 8-module course, which will be members, again, it'll be for our membership, and it'll be much more specific on, you know, how do you read an agenda? How do you develop a response at one of these meetings? Sometimes we have to give 2- and 3-minute statements at the World Health Assembly or at Commission on Narcotic Drugs. How do you write a 2-minute statement? It's like haikus. It's really challenging. How do you build relationships and identify who you need to work with? So that's in the works right now. And then we'll put the original basic advocacy course on our YouTube channel. So those of you who aren't members or can't join at the moment, check out our YouTube channel, IHPC, International Association for Hospice and Palliative Care, because that's free. And we've got recordings of some of the events we've done this year at the Open-Ended Working Group and at Commission on Narcotic Drugs, and a couple of other ones. Recordings, those films are on the YouTube site, and we'll put the advocacy course on that site, so it'll be free. And then there will be the members only 8-module course, which will start in September, God willing, if I can get that together with lots of other guest speakers. So it's not just me talking about different aspects of advocacy. So yeah, the main skill set is, Zippy, you talked about it in your intervention, is to be passionate, committed, learn the evidence, and be able to connect with people, with the policymakers, decision makers, media. You have to be able to speak with authority, because you have, one of the principles I didn't talk about in my slide on principles was, it's a concept called proximity. Actually, Pope Francis talks about this a lot. It's being close to, and when you have that proximity to patients or to suffering, you're able to speak authoritatively about how to relieve that suffering. And that's why you, Zippy, and your nurses, your physiotherapists, your spiritual care providers can do really good advocacy, because you have proximity to suffering. And of course, the patients are the ones, and the family members. So it's not a skill set really, but it's being willing to immerse yourself in suffering. It's hard. So that's why you need the self-care piece and the team. it's all self-care with a big S.
Thank you very much, Catherine. There are lots of very nice comments on the chat. People are realizing it's a very interesting and very nice presentation. Thank you for that.
Thank you.
I think we actually, just to follow for the Kenyan team, and also everybody's welcome to this. We'll share with Catherine, so she'll share with you. We'll be having a session in August by Dr. Esther Munyora. I don't know if she's on this call, but she's going to be sharing about how she started the palliative care unit in the National Hospital. And it needed a lot of advocacy. She had to do a lot of, we have never had a unit in a public hospital before. This was the National Hospital that has over 2,000, 3,000, 5,000 patients. And she was bringing up this idea of starting a palliative care unit, something strange to people. They knew there was a hospice there, so why do we start this? And she'll be sharing in August, sometime in August, it will be announced about her challenges and how she used her advocacy skills, her leadership skills to ensure that the unit was started. So we'll be hearing more about this. I was just going to, I don't know if anybody else, I'm not seeing any more questions, but there are many comments. I don't know if we can give maybe one patient advocate a minute to say something. I see Lucy Watt there. I don't know if she's still there. Lucy, would you like to say something so I can ask Josephine to, David to allow you to say something? I see, I think maybe Rose from Uganda, if she can say something about how they managed to get even nurses prescribed in Uganda. Just 2 minutes each, because we still have some 20 minutes, and then we'll come back to have Catherine close with if she has any closing remarks. And if there's anybody who has a burning issue, you can raise your hand up. We'll start with Lucy, then we'll go to Rose. Lucy, I think you have been.
Yep, I have been unmuted. What did you want me to say about a little bit about?
I'm just saying, maybe you as a patient advocate, what it has meant for you. And actually, you've been an advocate up to the UN level. You have met with Tedros.
Yeah. So I got started on my palliative care journey as a patient, and really finding out there's not many patient voices on the UK stage or internationally. And it was ICPCN and then WHPCA and then obviously the IHPC working together to really get the patient voice out there. And I think there's something powerful about the connection. And I think that's what reached Tedros in a different way. He met me, I'm the same age as his son. He really could relate to that story. And I think because my story is so positive, palliative care means I'm here 10 years beyond my prognosis, living a fantastic life, doing so many things. And I think people don't understand the value of palliative care. They see it as a kind of one-way ticket to death. And actually for me, it's been the one-way ticket to an amazing life over the last 10 years. And I think stories are so powerful in the connection they bring. Statistics are great. They really do shock. They can empower, they can educate. There's something about story. And I think if we can relate palliative care advocacy to real stories, stories of patients, parents, carers, professionals, it is about us as people, and it's our stories that will make change.
Yes. Thank you so much, Lucy. I know you've been a great advocate, and I know that because of what you meeting with Tedros sometime back, he actually gave us 2 sessions this year, isn't it, Catherine? Yeah. He gave us 2 sessions just for palliative care, and that was really great. Thank you, Lucy. We have Rose. Maybe David, you can unmute Rose. Rose was the executive director for Palliative Care Association of Uganda for many years, but the first palliative care nurse in Uganda. Rose, go ahead.
Thank you very much, Zippy, for giving me the opportunity and for organizing this session. Catherine, this was really very good. Thank you so much. Very important presentation. I am a retired nurse, now at home, and I want to say that advocacy, as you rightly put it, Zippy, is for all of us. And when we work together, we can achieve a lot. When I retired, I was like, okay, let me sit home and relax. And then people started asking me, what have you been doing? I said palliative care. And they were like, what is palliative care? I couldn't imagine that I had spent 27 years in palliative care and my village people didn't know. So I decided that I would do actually primary health care and make sure that palliative care is heard in my village. So started a small CBO, started like just a small group with a few neighbors, told them that palliative care is about ABCD. And they were like, how do we do it? Then we went with friends to visit a patient. And they were like, is that what you do? we need to do something like this in our village. And in my village, there are many healthcare workers. So I mobilized the healthcare workers. There were also community volunteers who are working with different organizations. I brought those ones on board and we started having meetings. That was last year before the lockdown. And we went visiting people and they were amazed at how palliative care can change somebody's life. We brought on board the local council leaders, and now the whole village is actually geared up. They want to make sure that everybody in the village who needs palliative care should get it. You will be surprised that much as you're in that community, you're doing a lot of advocacy up there in the district with the policymakers. Your own people in the community don't know. So we've got to make sure that our people right from the grassroots understand what palliative care is. There will be also advocates, but also they will demand for those services because it is coming from the grassroots. They now understand it, other than we standing in parliaments and talking about this and people don't know what palliative care is. So we need to take all directions to make sure that people understand what palliative care is. You were talking, Zippy, you asked me how we got palliative care into the nursing curriculum. Yes, palliative care is in the nursing curriculum now, is in the medical curriculum, but also we have a standalone program in the government in the government nursing schools. They are doing a diploma in palliative care. Initially, it was only Hospice Africa Uganda offering the diploma in palliative care. Now, the nursing schools are offering palliative care in nursing, the palliative care nursing diploma. And the Nursing Council has recognized it. They are accepting them, which was a journey because you've got to bring those people on board. You've got to make sure that they understand what you're talking about. We had also to look for sponsorship to make sure that we train the tutors so that they understand what palliative care is and they are able to talk and advocate on our behalf and also train the other people. So we are so proud that we have a diploma in palliative care for nurses, and it's called Advanced Diploma in Palliative Care Nursing. We've got a degree in palliative care nursing that is for all. And we've also gotten a master's now in palliative care, but it has not been simple. It's a long journey. It has been a long journey, but what is important is to work together, bring everybody on board. And if you can get one of those policymakers with a patient and they invite you, do whatever you can to make sure that you make their patient comfortable and they recognize the importance of palliative care. Thank you. Over to you, Zippy. I hope I've not talked so much.
Thank you. Thank you so much, Rose. One of these days we'll get you also to come and give us CME. Yeah, we are following your footsteps. We actually now have a diploma in palliative care. We had one previously by the Nairobi Hospice and Oxford Brookes University. And about 6 years ago, we started one. We started one at the Kenya Medical Training College for Nurses. And slowly, hopefully, that will catch up with Uganda and have a degree and a master's as well. All our students are going there. You're stealing all of our students, but it's okay. Yeah, so somebody has asked, do you have any problems in your country with the police related to appointment of painkillers, especially morphine? Maybe I'll just answer on behalf of Kenya. We don't really have a problem with the morphine that we use for patients. Our laws, our regulations are actually becoming even more friendly because our country recognizes that we need to have opioids for pain management, for medical purposes, for scientific purposes, but of course also our law focuses a lot on the trafficking of these medications. So we don't really have an issue. We might have issues with other, recreational things out there, but we have not really had a major or actually even a problem with the morphine that we are using for patients. We don't even have enough morphine for our patients, so we can't really even divert it to other things. We are allowed to prescribe opioids even up to a month if a patient is living far. The regulation is that it has to be a registered doctor who prescribes, or a dentist if for dental purposes, or a vet for veterinary purposes. And although we know that we don't have enough doctors to prescribe, the nurses who have been trained in palliative care and are mostly the ones who are manning the hospices and palliative care units actually can also prescribe and dispense under supervision of the doctor within their facility. So our laws are friendly to our patients. We don't have issues like no access to oral morphine. They can only come in for injectable morphine. No, we have oral morphine, and it's being actually bought by the government right now after a lot of advocacy. The oral morphine is actually being supplied by the government. It's manufactured in the National Hospital, and then from there it goes through the chain, supply chain for the public system, and it goes to the hospitals and sometimes to the hospices, or they have to get it from their public hospitals. So I wouldn't say that is a big problem for us. I know other countries face a lot of issues on access to opioids, but maybe Catherine, you can actually tell us, the issue of balance. How can people use this? The laws on balance, the narcotic board. What does it say about access to opioids?
Do we have another half an hour at least?
No, just briefly. We have about how many minutes left? We have about 10 minutes. Yeah.
Yeah. Okay. First of all, I just want to say thanks to Rose. I will do that, Zippy. Because and in fact, last time I was in Uganda, Rose, I can't remember. I think it was for the Congress or for the Palliative Care Uganda conference. You had the narcotics police, is Isaiah, the head of the narcotics police there, and you had all the actors in the whole supply chain of medical opioids in the same room talking about exactly how to solve those communications problems, barriers, and he is now on board, as far as I know, and if there's time, you could clarify that, Rose, to change the law in Uganda so that nurses don't get criminalized, because the way I remember it, Uganda updated its drug law in 2018, I think, and you'll correct me if I'm wrong. And they forgot, I guess it was, to put in some kind of clause amending, allowing nurses to carry liquid morphine, which everyone was used to doing on home visits. So theoretically, nurses, and in fact, one or two of them were, I remember, criminalized for transporting morphine because the legal framework of the country didn't explicitly allow for it. So there's a huge amount of work to be done because, as I said, most of the drug policy in the world, both at the global level, the regional level, and the national level, is focused on control and prevention of diversion and abuse. Even though, and this is what's so frustrating, there's no research, there's no evidence of diversion and abuse in most of the services where oral morphine is provided for patients. The American opioid overuse crisis, I refuse to call it a pandemic because it doesn't affect the whole population, is casting a chilling effect on the rest of the world, because they're pushing this narrative that the whole world could become addicted to oxycodone and fentanyl, and everyone is going to be dying from overdoses, so you have to restrict access to medical opioids, which is ridiculous, because they're completely different situations, completely different drugs, and I'm using the word drugs there explicitly because there's a lot of illicit manufacture of fentanyl that's causing the overdoses, whereas the patients themselves who were safely using opioids for years and years were not having problems with diversion and misuse. So it's a huge problem now for the rest of the world, and it's why the Ensuring Balance Guidelines, which were a great document, was withdrawn. But that's, again, a whole nother story, and there will be a module on that in the new advocacy course. I just wanted to say that what you said about creating demand was correct, Rose. That's what we have to do. So we work at all those different levels. You create demand from the ground up. We create the legislative framework of authority at the international level. You also work at the national and regional level. But it's really important to do advocacy, and I know you know this too, Zippy and Rose, with faith communities. I just watched a short video yesterday from Malawi that was posted by Jane Bates about how the communities in Malawi, the palliative care communities, have made alliances with different organizations, including faith communities and traditional healers. because they're really the way in. Half the faith communities don't know what palliative care is either, probably more than half. And they need a lot of education. They need to be brought on board. So many people mainly go to traditional healers first and try all those medicines, and traditional healers often don't have that interface with clinical palliative care providers. So I know Uganda's doing something with that. I think you are too, Zippy, and those are all important advocacy pieces. But the principle of balance is really that, yes, you want to stop harmful drugs from negatively affecting the community, but we also have to have appropriate medical access to opioids, which is why I did that odd drawing at the end with the timeline, because it's so new. We've got 50 years of against drugs and nothing except 6 years, or I mean, professionalized 6 years, but 20 or 30 on informal advocacy. But the principle of balance is just not engraved in everyone's minds at the moment. They're also frightened of overdoses and opioids because they don't understand training in palliative care.
Great, thank you so much. Thank you so much, Catherine, for responding to that. I think we still have a lot of hurdles and challenges to overcome globally. I see there's one more hand. I think Eric, is he still on? Eric, I don't see him on. Is his hand still on? Eric, oh yeah, Eric Hamisi, did you have a question to ask? David, can you unmute Eric, please? I will take Eric as the last question. David, would you like to unmute Eric? Am I able to unmute him?
Yes, he's unmuted.
I see like he's still muted on my side. Maybe he needs to unmute himself also.
Yes, he needs to.
Eric, can you unmute yourself so that you can ask your question? Or is your hand up by mistake? It has been upward, I think.
Maybe by mistake, okay.
Okay, all right, so we'll lower his hand and then thank you. I'll be coming to the end of the session. I really want to say thank you so much to Catherine. Thank you to everybody who has attended. Thank you to those who have asked questions. Thank you for Lucy and Rose for putting you on the spot, but you responded. Thank you so much. Rose, you have given me ideas for my retirement. Thank you for sharing your ideas. And so I'll give the final word to Catherine to just give us a final word of advice.
I'm not.
And thank you to David. Sorry, thank you to David and Howard who are behind the scenes. Thank you very much. Yeah.
And I would just thank everyone for attending. It's what gives me the energy to keep doing this, is that people all around the world are trying to do the same thing and relieve the suffering of patients and families as much as they can. I think it's important to, if I had one last word, to just say, get the sense that there's a global palliative care movement and you're not on your own. Even though sometimes it just feels so hard and it's just you and your team and it's just a huge mountain to climb. Kilimanjaro, you've got in Kenya. But there is a global movement. We do have the wind at our back. It's a long, long road to hoe. So we got to do it together in solidarity.
Thank you. Thank you very much. Thank you, everyone. Thank you, Kehpca team behind the scenes. I'm sure the ones who are flying have landed. I hope they managed to get to the last bit of this session. Thank you. I can see even Dr. Asaf and the rest, everybody that's working in hospices. And a lot of thank you, wrong English, but a lot of thank yous to our regional, East African and global participants. Thank you so much for joining us. We usually have these CMEs twice a week. We bring different topics, interesting topics. We know we can get through you we can get to you through Catherine. So we'll keep on sending our CMEs to Catherine so that if you feel that there's one you'd like to listen to, you're always welcome to join us. Thank you very much. In Kenya, it's night, so good night. Those who are in Africa, good morning. Those who are in America, good afternoon, good everything, everybody. Thank you so much. Have a good evening, morning, afternoon. Yeah.
Thank you.
Okay, bye-bye. And it's twice in a month. CPU said twice in a week.
Oh, twice in a month, sorry.
Thank you.
Old age. Yep.